Thank you. So that was a really good start in terms of understanding where we are, what dry eye is. So let's have a look at the methodology. Again, subcommittee formed in this area. You can see them in that picture. Lots of financial disclosures, but none particularly relevant to this work. So I think the first thing we need to understand is, why do we want to diagnose a condition? Well, of course, it helps us as clinicians to know what dry eye is and what it isn't, and I think that's really important when it comes to management. And as you saw from that subclassification, it also takes away some of that uncertainty in terms of, well, actually this patient doesn't have symptoms, but can you have dry eye without symptoms? And what about those people who have general pain and describe some pain in their eye, but it doesn't seem to be caused by something related to the eye? We also have it, of course, for our patients, really important in terms of their understanding, actually getting a diagnosis so something now can be managed. Better understanding that condition is really important. But also for other people, such as funders. In a lot of markets around the world, how you get particularly your private medical insurance depends on that diagnosis. So there are a whole number of reasons why we need a firm diagnosis. And we can see some of the issues relating to a firm diagnosis when we look back at the original Hughes report and things like prevalence. Because actually, if we look at the studies, most of them found around 15% in a more Caucasian population, pretty much double that in an Asian population. But actually, if you look at the definitions that they had to go on, they're all very variable. So it makes it very difficult to do things like prevalence if you don't have a firm diagnosis. And again, as Jenny alluded to, if we look back at the original definition of dry eyes from that Hughes report from 2007, we can see that within that, people had interpreted that certain things had to be there for dry eye. So dry eye is a multifactorial disease of the tears and ocular surface that results in. So symptoms had to be there, visual disturbance, but did we have a good way of particularly measuring that? And tear film instability, but notice things like the potential for damage of the ocular surface. So that means it doesn't actually have to be there. So should that be part of the definition? And again, it referred to things like inflammation and osmolarity, which we didn't have at the time very good measures of, but it sort of indicated to a lot of people that that should be there. And also, they had recommendations via diagnosis, some kind of symptomology questionnaire, osmolarity, although, as I say, at the time, they didn't have a real measure of that, non-invasive breakup time, and then this tear function index. But actually, we haven't really seen people adopt that, and still there are many papers and many clinicians having their own way of diagnosing what they call dry eye. So our principal aim was really to lock this down and go, actually, this now is going to be how we diagnose dry eye for the future. So we've seen the new definition, the fact that it talks about this lack of homeostasis. Symptoms do need to be there, so it is a disease of symptoms and signs. We can have a poor ocular surface, so ocular surface disease, dry eye is a subcategory of that. And it's not to say that we wouldn't treat ocular surface disease. If you have a patient going through surgery, for example, may really be really important to not induce dry eye. You might have a contact lens patient who has ocular surface disease. Before you fit them with contact lenses, you would want to manage that. But it means that's not specifically dry eye. And this very clearly now defines that actually we're talking about the pathophysiology when it comes to things like hyperosmolarity, inflammation, damage, and the neurosensory abnormalities. So when it comes to dry eye testing, what tests do I need to do? And you'll see just a few of those tests appearing on the screen. There's a vast majority, a huge number of tests now in terms of volume, stability, osmolarity, inflammation, all these markers we could do. Well, if we had to do all of those, we would have some very long testing appointments. So how do we narrow that down? And as you can see here, the traditional way of doing this is with a sensitivity and a specificity. So let's actually find out how sensitive this test is for doing our diagnosis. So this is from the previous report, and we'll pick the best combination of those. But actually, there's some problems that come with that, and that was acknowledged in that initial report, that there are some biases when we do our diagnosis. And I'll explain those now. So here we've got our new test, dry eye disease diagnostic test, and I want to introduce it onto the market, and I want to know how good it is at diagnosing dry eye disease. So I recruit two groups. I recruit my group of normals up here, very happy people, and I recruit my disease group, so my dry eye disease group, and that allows me then to plot my sensitivity against my specificity, and basically the further we are away from this straight line, the more diagnostic my test is. But actually there are a number of problems. If I make the difference between my normal group and my disease group further apart, so let's say I recruit people with really severe disease, then the sensitivity and specificity of my tests will look much better. So now I can't really compare one study with another study. So doing something like that, that would improve my sensitivity and specificity, but it's just due to the spectrum of patients that I have. Alternatively, again, I could have my two groups, but I could sample differently. So actually, I could say, well, actually, I want all of these criteria for my normals, and then all of these different criteria for my disease group. So now there's a group in between those two that are neither. They're not normal because they don't fit the normal criteria, and they're not disease because actually my disease group is really tied down. I want lots of staining, etc. So actually, in terms of my sampling, again, I add a level of bias. And finally, I can actually move my test closer to those tests that I originally had. So actually, I've got to recruit my disease group to test my test against. So if my test is a volume test, and I diagnose people based on volume, surprise, surprise, the sensitivity and specificity is very high. Whereas if I actually have a new test which tests, let's say, inflammation, and I compare that to a standard test of tear film stability, then the sensitivity and specificity will be very low. So while we think of, yes, this person has a disease or they don't, actually, as we can see from this, it really depends on the criteria you choose. So arguably, you have to put your flag into the sand and say, this is what I'm going to call the disease. Now everything is going to be benchmarked to that. So essentially, that's what we did in the report. We looked through all of the different tests that have been proposed for the diagnosis of dry eye. And what we wanted to do is to select those that seem to have good diagnostic ability, were robust, and also that could be performed clinically, because you need to be able to diagnose these patients in your clinic. So this is what we came up with. So first of all, a series of triaging questions. Why? Because it's not just eye care professionals that diagnose dry eye. You walk into a pharmacist and they will diagnose dry eye. We've done quite a lot of work with the Royal Pharmaceutical Society recently on this topic. So actually you need some questions which make sure that actually it's probably likely to be dry eye before you start, and if not, that they actually end up in your practice having a proper management. So there are a series of questions to do that. You'll see that we've grayed out the mouth dryness and swollen glands because actually Sjogren's syndrome is part of dry eye, but we need to identify it separately because there are some ramifications and some specific treatments that are different for that condition. So having made sure that this isn't a general infection or something else that could masquerade as dry eye, then we're going to have a look at some of the risk factors, because it could just be that they're wearing contact lenses, and that's something that we need to manage in its own right. But also this will help us in the management as we move along. And then we have our diagnostic tests. And we start with a screening test. We've said already that symptoms need to be there. And as you see, and we'll talk about these in a bit more detail, we've got 2 symptomology questionnaires that we might want to look at for that, which are nice and quick to do, but can help us to indicate that this person probably has dry eye. And then we move forward, and we need one of the 3 following tests to be positive. Non-invasive breakup time. You'll notice that we have fluorescein there in brackets. There are still quite a lot of people around the world who don't have access to a non-invasive breakup time, and therefore, if you very carefully use fluorescein in terms of the amount you put in, for example, you can get an indication of tear film stability. We also have osmolarity. So again, a high osmolarity or a difference between the two eyes can indicate a dry eye in combination with your symptoms. And then staining is the other thing that if we see it combined with our symptoms, then we would diagnose dry eye. So that helps us to lock down what dry eye is and also those people who don't have dry eye. Now, of course, that's the diagnosis, but that doesn't fully support our management, so we need to go on and have a look at whether this is more of an evaporative type of dry eye, things like meibomian gland disease or lipid thickness that's abnormal, and also in terms of your aqueous volume. And this will help us then in our management steps. And then from that, there's a wide variety of management that Lyndon will talk to us about in a moment. So let's have a look at some of those aspects. In terms of symptomology questionnaires, of course, there are a huge number out there. There was with the original TFOS, even more now. And so again, we looked at the latest literature on those, the various different ones, the sort of cut-offs and things that they've done. But as I mentioned, it really comes down to these two questionnaires that we recommend, either the Ocular Surface Disease Index, which has 12 questions, or the Dry Eye Questionnaire, which has 5. Both very simple to do with your patients and allows you to track their dry eye with time. When it comes to non-invasive breakup time, there are a number of ways of doing this. You'll have noticed from the title it says live diagnosis, and we will do that in a moment to show you some of these. But looking at that tear film stability, you can see the breakup in that image on the screen. And also these instruments have the advantage that you can pull back slightly and have a look at the lipid layer for that subclassification. When it comes to osmolarity, more devices are beginning to appear on the market that can now do osmolarity, and because that's part of the pathophysiology, this again gives us a good indicator of dry eye. We do need to know about the variability between the eyes as well as the highest value from these measures. And then finally, we have ocular surface staining. We are looking at the whole ocular surface, so this is not just the cornea with fluorescein, but also the conjunctiva with lissamine green and the lid margins, where that combination works really well to have a look at damage. Now, staining is generally considered a late-stage sign of the disease, but we do see patients with significant staining, particularly of that conjunctival region, and the studies tell us that that is quite sensitive to treatment as well, so a good way of tracking your patients. So at this point, I will call Jennifer and Lyndon to the stage, and we're going to do a live diagnosis. And as I am rapidly getting dry eye, we're going to do me. So you can see the answers to my screening questions there in terms of I have a sort of mild discomfort, no swelling of the glands or a dry mouth. This has been happening over the last 6 months together with my presbyopia. Vision sometimes noticed, occasional contact lens wear, for example. So these indicate that it is probably pretty much dry eye, and we're not going to have to do a more detailed examination. We're going to move straight on to having a look at risk factors and then these diagnostic tests. So in terms of screening, well, we've done the DEQ, and you can see some of the answers up there. Let's get those up. So we can add those up, and we get a score of 9. So yes, we've got that screening test as positive, and that then takes us forward to our first tests on the slit lamp. Hand the mic over to Lyndon, and Jen will come and examine me.
So as James just set up, what we now do once we've done that initial diagnostic questionnaire, we know that we are looking at potentially a patient who has dry eye, but as we went through, when Jennifer went through the diagnostic criteria or the definition, we need now to do a number of other tests to confirm that it truly is dry eye. So this is where we now basically require our diagnostic test. So James has already taken us through what those options are. So I think we're going to start off with the non-invasive break-up time.
Great. Can we have the camera on the screen, please?
Yeah, so while we're doing this, we're going to be looking at this grid pattern here that you can hopefully see on the screen. We're going to be looking at the reflected mirrors of that. While I'm doing that, just before I do that, I'm just going to do a couple of small checks because This is a non-invasive test, and we want to do the things non-invasively first. We want to order our tests from the least invasive to the most invasive. So while I'm here, I'm just going to have a quick look at the tear meniscus and look at that tear meniscus height. So if you look here, you can see that the river of tears along the bottom, and you can see that actually it's a reasonable height. Okay, so you've got a light here that's a cold light, so it's not going to induce reflex tearing. It's also not got heat, so it's not going to dry out the tear film. So it's going to give us the most natural tear meniscus we can get. And you can see there that there appear to be plenty of tears present. So we're thinking at the moment, that's aqueous, looks not too bad. I'm also going to have a quick look at the lipid pattern. If you can blink for me, James.
So you can beautifully see the lipid pattern moving here.
Yep, so today we have a flow pattern. So, yep, we have certainly some lipid floating on the surface there. So that's a wave pattern that you can see present at the moment. It's a little bit difficult to see on the screen. You get better contrast on the slit lamp itself. Now we're doing this with an easy tear view. This is a clinical instrument, really small, easy to pack into your practice instrument that you can attach to a slit lamp, and you're able to get information that you can't get any other way. You can't get this with an ordinary slit lamp. So that's allowed us to look at the lipid layer, which is kind of a medium lipid layer. That's probably all you need to know at the moment. Now what we're going to do is we're going to go in and look at the tear film stability. So I'm moving further forward to get the grid into focus. What I'm going to do is I'm going to ask James to blink. And when he blinks, as soon as he opens his eye, we get a beautiful clear grid pattern. And then what we're going to watch for is the tear film destabilizing. So from here, we're going to say, if you could blink for me, James. Good. We're going to start recording, and we're going to say, please try not to blink now, James, for as long as you can. Oh dear, look at that. Right. Okay, that was a very, very short break-up time. So we'll try that one again. And reset.
He's not very good at being trained, actually. That's the problem. His tear film, we've been trying for days, but...
Yeah, and he's not getting better. Okay, so from here, let's try that again. So we're going to say, blink for me, please, James. Good. And we're recording the time, and you start to see the tears destabilizing towards the bottom. Can you see that? Are you pointing out the destabilizing?
It's really fast.
So 3 seconds at best here. So we reset that. Oh, it's great. Okay, so blink for me again, please, James. And we reset the recording. And we're looking for, again, you can see that breakup starting to occur towards the bottom left-hand side. Yeah, can you see that? Yep. Good, yeah. Sorry, I didn't record that one. Okay, and one more time.
Pretty naff useless, basically. That's the tear film here. That's
the tear film of a professor. Yeah. Yes. And you need to take 3 readings. The tear film is inherently variable because of the difference with the quality of the blink. Your tear film stability measurement can vary, so you want to take 3 readings and take an average. And so one more, James, good. And we're recording, and you can see that breaking up already. Yeah. A quality, 3.8 seconds.
They told me we weren't allowed a long time on stage,
so I thought we've been training them.
Quick tear breakup time.
Training them to come down. Okay, so from here, we're now going to start to look at the tear film osmolarity. If you remember if we can go back to the slides, please. After you've had a look at the non-invasive tear film stability. Cool. The next one is going... Yep. The next one is going to be the osmolarity. So for that, we're going to use the Tear Lab, which is a clinical instrument which allows us to measure tear film osmolarity. Now, what you need to do with osmolarity is you actually need to measure it in both eyes. And what you're doing is you're looking for the highest reading of the 2 eyes. And you're also looking at the difference between the 2 eyes, because we know that the tear film osmolarity increases in dry eye. I now see the wings that people referred to. Good. So this is coming in and collecting a 50 nanoliter sample, and we then analyze that. So we put that onto the device here. It's going to read that carefully. Now, while that's happening, I'll try not to freak it out by taking the other pen out and measuring the other eye.
All right, so we've got a measurement of 310. So
Not
310.
brilliant. No, sorry. I mean, it's a little bit dry. So let's see what the other eye shows us. Good.
So dry, could hardly find his tear meniscus then.
Pretty much. Now, when you're doing that, you're doing it very carefully because you don't want to induce reflex tearing. If you induce reflex tearing, you're going to bring the osmolarity down because you get a rush of reflex tears straight from the lacrimal gland. So let's see. Oh, right. Okay, so we have 320 in the other eye. So 310 and 320. We go with the higher reading. That's the one that we record as the osmolarity for James. It's like blood pressure. You just get one of them, whether you measure it from one arm or the other. We only want one measurement. So we've got an osmolarity of 320 for James, and then we've got a difference between the two eyes of 10, and that's another indicator. That one's really, it's helpful to know what the difference is between the two eyes. The higher the difference between the two eyes, the more likely it is that it's dry eye.
So we already diagnosed me with dry eye because we've got the symptoms plus, well, either of those would have done, the osmolarity or the tear breakup time or the difference in osmolarity.
Yeah.
But we'll do the staining to be complete as well. So we're going to use fluorescein because that's a good corneal stain, but also lissamine green, particularly for conjunctiva and the lid margin. Now you've got to be really careful when you put your fluorescein or lissamine green in, because of course these are the tissues that we want to look at. So it's no good just wiping it across the temporal conjunctiva. You really do have to put it on the outer temporal canthus so you can still look at those various regions.
Come forward then and we will do that. Cool. Lovely. And then I'm also going to put in lissamine green at the moment as well. So lissamine green, oh, you'd want to.
So another big difference, so with fluorescein, we obviously put the drop of saline on the fluorette, then we flick off the rest. We want a minimal amount of fluorescein in there. With lissamine green, the more the better. So actually we put our drop onto the lissamine green strip, and we hold it in position there for at least 5 seconds to get some mixing before we put that whole drop into the eye. So you get a nice green eye.
And you say to the patient, blink really, really gently. Good.
Oh, well flooded.
Oh, yes, that's nice. Nice and green.
Okay, so what we're going to do is we're going to check the fluorescein staining first. We've put both stains in at the moment. They look at slightly different things. The fluorescein is looking more for epithelial cell loss. The lissamine green is looking for primarily dead and devitalized cells, but also looking for cells without mucus cover.
There's a yellow filter built in.
There is? Where? Cool. Do you want looking at your left? No.
You're doing the right
no, I'm noting your right. It's all right. Okay, so is that as blue as it goes?
Yep.
Okay. And as white as it goes?
Yep.
What have I done?
Yep.
Yeah, we're good. Okay, we've just got a little spot that's following around. So we're looking at the corneal staining. Blink for me, please.
Let's look at all that debris in his tears as well.
There's
You're a
couple of
mess,
little
boy.
spots. You
You're
see
a mess.
A couple of little spots there. Obviously, with dry eye, you're tending to look in the interpalpable zone as being the region. Look at the good breakup with the tear film. You're looking more towards the interpalpable zone for the area of drying in dry eye. So we're covering mostly the cornea. We're looking at with fluorescein. It's easiest to see the fluorescein staining on the cornea. We're then going to have a look. So we've got a few spots there, a few dots. We're now going to go white light, filter out, and we're going to, oh, that's going to be bright. And then we're going to have a look to see if there's any lissamine green staining. And this is where we're looking, oh, there is. This is where we're looking at you've done really well in preparing yourself for this workshop. Can you see oh, you can't.
It's a bit too over.
Let's
Put the diffuser on, you might see it better.
There you go. That's
put
beautiful.
the thing up. Yep.
Yeah. Fabulous.
Yeah, so you can see there are various dots there. And so it's easier to see the lissamine green staining on the conjunctiva. Yeah, the contrast is a little bit better again on the slit lamp, but you can see there are a few dots, not that blob. The blob isn't there. Blink for me. Good. Yeah, it's got a bit of mucus staining. Yeah, there. Yeah, that's gone. So you can see the kind of slightly patchy few dots there on the temporal conj. And if you just look over this way for me, and we've got a patch here as well of staining. So James ticks all three boxes. Never one to not go full haul and everything. Yep, we've got some staining. So we've got the poor stability, and we have a higher osmolarity, and
half measures,
and some staining.
Things I do for the BCLA.
I think we can diagnose a dry eye from that.
Great. So if we go back to the screen now, so having done that diagnosis, we'll now move on.
I want to do one more thing, actually. Just invert your lid, because the other thing to remember is that when we're doing the staining, it's not just the cornea and the conjunctiva, but the other thing we want to look at is the lid margin. We're looking for lid wiper epitheliopathy, so we're going to get James just to look down.
If we can go back actually to the view on the slit lamp. Can we just change back to the view at the slit lamp, please? That's it, thanks.
And we can see from there that you've got a good... The green line that you're seeing there is Marx's line. That's the mucocutaneous junction. So that's normal to have that stain up. It should be a nice, thin, even line, and that's what we're getting with James. So we're not actually getting any lid wiper epitheliopathy there specifically. Maybe a tiny bit towards this direction. We're starting to see it's thickening a little bit. So you're looking for that zone. The thicker the zone is, the greater the lid wiper epitheliopathy. And so you're getting a little bit towards the nasal side there. Cool. Well done. Okay. So that's the upper lid wiper. You'd also check the lower lid wiper.
So having done that diagnosis, looked at those three different areas, so the cornea, conjunctiva, and the lid margin, then we're moving past the diagnosis. So we've definitely got a diagnosis in my case. We're looking to see now that balance between aqueous deficient and our evaporative. And we've already had a look at tear meniscus height, and that was quite good. So
tear meniscus height was good.
Suggests that it's probably going to be more on the evaporative type side. But we can also have a look at things like the glands and the expressibility, which we can do now.
Cool. So what we're using to look at the expressibility here is the Meibomian Gland Evaluator. Looks remarkably like a USB stick. Doesn't work very well as a USB stick. It's a very, very carefully calibrated spring, and it's giving us the force when we use that on the lower lid margin. It's giving the force of the equivalent of a blink, of a forceful blink. So if I come in here, and what we're looking for, I don't know, have you got the lid margin there? Yep. What we're looking for is to see if we see any expression from the glands when we depress this.
Just out of, there you go.
Can you get that in focus?
Pretty close.
And you can do that, you can work your way along. Sorry, it's a bit awkward with this one. And so you're looking to see if any of the gland, you get a little bit there. I don't know if you can see it's a bit tricky to see. You're getting a little bit of glistening there on the surface, and that's the glands expressing some oil, but there's not a huge amount there. Let's come in from this side. I'll see if that works better for the video. And so you do that 3 times along the lid margin. And we're not getting a huge amount there. I don't see any extra glistening there. So we got a few glands, but not very many glands expressing. So that would make us think, yes, this is more towards an evaporative dry eye. We actually saw some lipid when we looked at the lipid on the surface. There was some lipid there, but it's, somewhere around about the middle. We're getting a few glands expressing, but not as many as I might like. And the other thing I'd want to check is to see whether what the glands look like, the gland morphology, when you invert the lids. And if you look with infrared, you can actually see on mybography, you can see the individual glands, and I think James has a picture of that.
Yeah, so we'll put back up to the slide. So you can do this with things like the Easy Tier View. The problem is you need an infrared sensitive camera, and this isn't. So we've done one for you.
For today.
So if we go to the next slide, there. So you can see my glands, a bit shocking again. So quite clearly areas of dropout, non-extension through to the margins. Interesting, the lower lid, if you looked at it, is pretty good still, maybe a little bit of extension, but it's mainly the upper lid that seems to be affected. So you can see there the test starting to tell us now that this is probably a more evaporative type dry eye than an aqueous in my particular case. And that leads us on then to the next slide. So there are a series of videos that will be available on the JEWS 2 site, which will take you through each of these techniques and actually many of the management techniques that Lyndon will talk to you about as well. And then the next slide will take you through to the fact that we've done these steps, and that leads nicely on to the diagnosis.
And I would just like to say one more thing, is that it's not all doom and gloom, even though you're probably feeling really sorry for James now. But we should be pleased that when we look at his mybography, he does have glands there. So there is the potential to do something in terms of treatment. So when we're looking at mybography, we're looking to see whether there's the potential for the glands to work better. And I think we can see that with James. He has plenty of glands there that we can try and get to work better. It's just to put in a bit of effort.
So that's our time on stage. So we'll get off the stage and we'll leave it now to Lyndon to take you through, having done that, what are your management thoughts?
Round of applause, ladies and gentlemen.